And I'll welcome everyone to this COVID seminar, the Neurological Associations of COVID-19. This is our second seminar in the series, so thanks very much for joining. My guests today are from Erasmus in the Netherlands. We have Professor Bart Jacobs, and from the National Institute of Mental Health and Neuroscience in India, Dr. Netra Bhatti, Netra as we know her. I'll ask them both to say hello and tell us a bit about themselves, just a sentence or two. First of all, Bart.
Well, thank you, Tom. First of all, thank you for inviting me to this wonderful seminar. I'm a professor in neurology and immunology at Erasmus MC in Rotterdam, the Netherlands. My special interests are inflammatory neuropathies.
Thanks very much. And Netra.
Hi, Tom. Thanks a lot for giving me this opportunity. Good afternoon, everyone. I'm Dr. Netravati. I work as an additional professor at National Institute of Mental Health and Neurosciences, Bangalore, India. I work on CNS demyelinating disorders, MS, multiple sclerosis, NMO, neuroinfections, autoimmune encephalitis. And thanks to all the participants who have joined this webinar. Thank you.
Absolutely. Thank you very much. So at this point, we usually ask the participants to have a go at sending us a message so we can check it's all working. So if you're on the Zoom thing, if you like, just tell us where you're from, which city, which country. And if you're on the Facebook thing, then please just send a tweet. And the way to send a tweet is to tweet at Running Mad Prof. And then we'll know where you all are. We'll know you're getting the messages. So do just send the message now if you like via the chat function, because we're going to be asking you to send some questions and comments in a little bit further along. Whilst you're doing that, by way of introduction, I'm Tom Solomon. I'm Professor of Neurology at the University of Liverpool and the Walton Centre NHS Foundation Trust that you can see here. It's a big trust providing care, neurology care for patients across the northwest of England. This is the University of Liverpool Institute of Infection and Global Health, where a lot of our infection research is based out of. And I head the Brain Infections Group, which is a large group with some senior colleagues now looking after the various disciplines within the group overall. We host Brain Infections Global, which is an international collaborative to look at neurological disease caused by infections. And on the website, you can see here, there are some training aspects. So we have every year a neurological infectious disease course. And then in addition, we have e-learning, which you can see here. We've had lots of people take advantage of that. In terms of the Brain Infections Global, we've got 19,000 visitors, 1,800 members. Do check out the website if you wish. This is the course. Like I said, the neurological infectious disease course runs every year in June. Not run this year, of course. And then those are the NeuroID e-learning modules. Those are freely available online. So the other thing you'll see if you look at the website is we have some COVID resources here. These two tabs. This is the COVID Neuro resource. So this is updated daily and lists any publications which are relating to COVID and neurological disease. It has publications in the proper journals, and then also pre-publications that are not yet being accepted by the journals. The next tab is the COVID Neuro Network. So this is a chance for you to join our team looking at neurological associations of COVID. And through this network, you can access freely our case record forms, so you can record your data, and also the case definitions. And it's really important that people do use standard case definitions so that we all agree we're looking at the same things. And we've now launched our individual patient data meta-analysis. So people who are collecting data using those forms are, if they wish, sharing their data with us so that we can create a meta-analysis of all the neurological associations of COVID-19. We recently published, it's not quite published yet, it's in press, and it's available on the websites, including the one I showed you earlier. This is our paper with the Lancet Neurology, summarizing all the data to date on neurological associations of COVID-19. So most of those papers are going to go in the individual patient data meta-analysis, along with any other data that people want to send us. So do please get in touch if you're interested in joining this. Okay, let's move on then. So I'm going to move on to our first speaker, and it's a great pleasure once again to welcome Dr. Bart Jacobs. And I think at this point, Bart, if you share your screen with us, and do please, if you're listening, send in questions. And at the end of Bart's talk, which will be about 10 minutes or so, we will feed in some questions and get some discussion going then, and then we'll have the second talk. Okay, Bart, do you want to share your screen? I'll stop mine.
Tom, there is a bit of an echo in the when you speak. Can that be solved?
Yeah, I'll tell you what. Hang on a sec. Let me just, I might have to fiddle a bit. How's that? Is that better?
Yeah, that's better.
Yeah,
Perfect.
Before you start talking, I've just got to fiddle with my screen, which in fact, if I mute myself, it'll be fine.
So can anyone see my slides? Okay. Thank you again, Tom, for inviting me, and it's a real pleasure to present our first results on the Guillain-Barré syndrome following SARS-CoV-2 infection. I'm presenting these data on behalf of the IGOS consortium, a group of international neurologists that are very much interested in research in GBS. So for those of you who are not really into this field, the Guillain-Barré syndrome is a rapidly progressive immune-mediated polyradiculoneuropathy. So it is affecting the nerves and the nerve roots. It is associated with preceding infections, which are found in 2/3 of all the cases with symptoms. And the Campylobacter jejuni is the most common infection, but there are numerous different types of preceding infections associated with the Guillain-Barré syndrome. Sometimes no association is found, and also other triggering events have been documented, like vaccinations. What is very important is that some of these preceding infections seem to be related to a specific clinical variant or an electrophysiological subtype of GBS. And of course, that's a very important finding, because that can help you to define if a preceding infection is really associated with GBS or not. So in the last 15 years, there have been numerous outbreaks of infectious diseases that have been related to the Guillain-Barré syndrome. Some of them are related to Campylobacter jejuni. That's the most frequent, but also most firmly established associated with infection related to GBS. Then an important infection is Zika virus that largely affected Latin America, but also in other countries in the world. Cases of GBS after Zika virus infection have been recorded. And of course, now there is an interest in COVID-19. And I think one of the key questions is this a chance finding, or is it a real association? Because if the world is now having, let's say, 5% of the patients infected, you would expect just by chance that also 5% of the Guillain-Barré cases will have this COVID-19. So is it more, or is it the same than what you would expect on the background incidence? This is a summary of the literature published so far. And these are largely individual cases or case series. In total, 33 cases have been reported, but I have to underscore that these are all uncontrolled studies. And what the authors describe that are the typical infectious symptoms related to COVID-19, including diarrhea that can be found. The time course is very important, because there is, of course, if there's a true association, a debate if it is an infectious disease or if it is a post-infectious disease. GBS is typically post-infectious. So the time between infection and first neurological symptoms is very important. The clinical phenotype seems to be a bit of a mixture of cases with sensory motor variants, pure motor variants, Miller-Fisher syndrome. That's largely involving the oculomotor muscles, and a pharyngeal variant. In the EMGs, there's a demyelinating form and an axonal form, both reported. There's respiratory failure in 42% of the cases, which is a very large proportion, because if you compare that with literature, it is usually about 15 to 20%. And 6% of the patients died, and 12% are still ventilated. Of course, you have to realize that these are usually highly selected cases based on ad hoc retrospective studies on case files. So this is not a systematic search in GBS at all. What we have the opportunity is in the International GBS Outcome Study, or IGOS, that is to offer such a standardized protocol for collection of data and samples. And that study started in 2012 and is still ongoing. And we have now included 1,902 cases from many hospitals, from many countries, from 5 continents, which is very important because in that way you can also compare GBS from different regions. It's a multi-center observational cohort study, so it's not interfering with the treatment of patients. It's important to realize that all patients can be included, at least if they are within 2 weeks of onset of weakness. So that can be mild cases or severe cases, treated or non-treated cases. Children can be included. Rare variants of the Guillain-Barré syndrome can also be included. And the reason why we have this is to get a good overview on the real world, let's say, population of GBS patients. And because we are collecting highly standardized clinical data and treatment data, electrophysiology and serum samples, we can test these patients extensively for preceding infections, antibodies to neural targets and other biomarkers. So we have recently started a sub-study on GBS in relation to SARS-CoV-2. So we indicated that these patients were in a defined window when the pandemic was ongoing. And we started the study on January 30. And the reason for that is that at that date, the WHO declared the COVID-19 a public health emergency of international concern. And when we continued until May 30, and all these data were collected in a prospective, highly standardized way. Our aims primarily are to describe the clinical presentation and course in relation to the infections and determine if there's a possible association between GBS and SARS-CoV-2. I have to underscore that the data collection and analysis is ongoing, but I would like to share our first results with you. So this is a slide that was made by Linda Luiten, a PhD student in our team that is working on this project. And during this time window of 4 months, we were able to include 42 cases of Guillain-Barré syndrome in IGOS, thanks to the IGOS consortium. And as you can see, these patients were derived from various countries. Of course, these are patients that may have a very different trigger than SARS-CoV-2, but I think it's very interesting to take these patients also in the study as a control. 7 of these cases were already confirmed patients with a preceding SARS-CoV-2 infection defined by the WHO case definitions. That number may be higher, we do not know. And that's still part of our ongoing research, but at least 7 of these cases in this cohort have now been identified. I just would like to present 3 cases in this cohort to give you a bit of a feeling of the type of GBS that is seen. So this is a female of 61 years old who had an upper respiratory tract symptoms 3 weeks before the start of the neurological symptoms. And she developed a rather typical GBS with facial and bulbar weakness, sensory deficits and pain, limb weakness, and we are using an MRC sum score for that. 60 is normal and 0 is a full tetraparalysis. And she had a score of 49. She also had autonomic dysfunction and was bedridden, chair-bound. The CSF and the EMG were typical for GBS, and it was a demyelinating form. The patient was receiving a standard IVIG course of 5 days, 2 grams per kilogram. And the outcome after 4 weeks is that he was able to walk independently. So she had a rather good outcome, but she also had a mild form of GBS. This is a male person of 64 years old, also with upper respiratory tract symptoms before the start of the GBS. That patient was bedridden and had oculomotor, facial and bulbar weakness with sensory deficits. The patient was a bit more affected for motor symptoms than the previous case, and the patient had a severe ataxia. Also, the CSF was typical, an EMG was not performed, and the treatment was standard, and the outcome still needs to be determined. And the third case is a male person of 50 years old with an upper respiratory tract symptoms 4 weeks before the start of GBS. That patient was rather severely affected because he was unable to walk independently, again had facial and bulbar weakness, sensory deficit, a mild proximal limb weakness in the legs, and ataxia. Also there, the typical CSF finding for GBS, and this was a demyelinating form of GBS. The treatment was again with the standard IVIG, and the outcome after 3 weeks is that the patient is able to walk independently again. So what you can see is here a kind of mixture of patients, although all the patients have cranial nerve involvement and limb weakness, a sensory motor form, and usually a demyelinating form of GBS. If that is really the typical phenotype of GBS related to this infection, we still have to define when we have all the data complete. So what would we like to do in this ICOS sub-study is to further examine these patients, of course, test biosamples for serology to SARS-CoV-2 and for other infectious agents related to GBS. And I think that last one is very important because that may bias the results, and you hardly see that in the case reports published so far. So that still can be, let's say, Campylobacter triggering GBS and just this SARS-CoV-2 as a chance finding. We have planned to do a case control study to determine if there's true association between SARS-CoV-2 infection and GBS. And of course, we have the full cohort of 1,902 patients in ICOS that we can use as a control to see if there's a related clinical or electrophysiological subtype. And then we would like to perform extensive immunological studies to see if you also find antibodies to the peripheral nerves and what is the exact mechanism of this triggering. But keep in mind that it's still unclear if SARS-CoV-2 can really trigger GBS or not. If there are people interested to collaborate with us in GBS or have any good ideas about collaboration, please contact me because we are very willing to consider further collaboration with you. So thank you for your attention.
Great, Bart, thank you so much. That was fantastic. So we have time for questions. If we'll stop you sharing your screen, and then I think that will bring up the three of us. And let me see. Let's see if that's worked. So the global health people could stop, or perhaps if I do that, will that do it? Just trying to show. There we are. Okay, good. So let's see. We've got some questions coming in, and do please post your questions either on Twitter or you can post them on the chat function. So first of all, we've got a question about how do we manage post-COVID GBS? This is from Krishnamurti. Do also let us know where you're contacting us from. We've got people contacting us from Nairobi, Vellore, Bangalore, the Netherlands, South Africa. So anyway, Bart, would you like to take that first question?
Yeah, so far, of course, these patients need to be treated without further knowledge as a standard GBS patient. That means that the two proven effective treatments are immunoglobulins and plasma exchange. So far, we do not have a specific recommendation for the treatment of these cases. If you are interested in the management of GBS, I would like to refer to our recent publication in Nature Reviews in Neurology, a paper that's called the 10 Steps in the Diagnosis and Management of GBS, a paper that can also be found by the Global Net Health Work So if you really want to have that in a step-by-step way, please look at my name or the name of the first author, Sonja Leonard. You will find the paper, or via the network, you can find that as well.
Great, thank you for that. There's a question here about, I think you said 5% of the population are now infected with COVID approximately. So you're trying to determine whether these patients just coincidentally have COVID-19. How are you going to, and you mentioned a case control study, somebody wants to know how you're going to do that, what the cases, what the controls would be, how that would work.
Yeah, so far we are not collecting controls in the IGOS. But we have planned for COVID-19 to start collecting controls. And what we are doing is that we are collecting hospital controls. So these are neurological patients with neurological diseases not related to COVID-19. And I think it's important that they come from the same time window and also from the same region. So we are now developing such a study, and the study has already started in few centers, and I especially would like to mention Switzerland, where already a network of centers is now collecting these controls, and I'm pretty sure that other centers will follow.
Okay, thanks. A question here now about antiganglioside antibodies. Have any been identified in GBS related to COVID-19, and do you?
That's an important question, because some of these preceding infections are related to ganglioside antibodies, and the very important one is Campylobacter. Most of the patients with Campylobacter infection have such antibodies. As far as I know, these studies have not been performed extensively in COVID-19 patients. So far, the cases that have been reported where the antibodies were tested, they were negative. And I must say that most of the patients which have a preceding viral infection do not have a related ganglioside antibody discovered so far. So the same accounts for Zika virus, for instance. But of course, that's all part of ongoing research.
Okay, a couple of quick questions. Are there any African nations involved in the study?
In IGOS, South Africa is involved.
Okay. And let me just ask Netra, are you seeing any GBS in Bangalore as well? Have you seen any of this GBS associated with COVID-19, do you think, or not yet?
I have not seen associated with COVID, but we are seeing few atypical forms, like only the cranial nerve involvement along with the polyradiculopathy. And there has been an increased spurt of Bell's palsy. I think Dr. Krishnamurthy sir has put up in the chat. There has been an increased incidence of Bell's palsy being reported. So, Dr. Bhatt, I would just want to ask you, do you think that could be a formifraste of GBS which is coming? And like what Dr. Krishnamurthy sir has asked, is there a role of steroids in them?
Sorry, can you repeat that question again?
In India, we have seen multiple patients with Bell's palsy, increased incidence of Bell's palsy. So do you think it could be a formifraste of Guillain-Barré syndrome? And is there any role of steroids in them?
Yes, I must say that's a question I don't know. You don't see that in the Netherlands. So that may be a variant of the Guillain-Barré syndrome, but that needs definitely further research. And of course, it would be very interesting to record those cases carefully and do all the routine diagnostic for them to be absolutely sure about the diagnosis. But I think at present, I cannot answer that question.
In fact, all of our patients whom we are suspecting on COVID, they have to be undergoing under an app from the government. So if they are not having a preceding upper respiratory infection, or they are not coming from the red zone, we are not able to test. So that is the reason all these people we are not able to test, though we are seeing the increased incidence of atypical forms. So,
do you think you are able to collect samples? Because you can always collaborate with other institutes that can test it for you.
Yes, I think that we can be able to do. In fact, we are trying to do that as part of the BI Global with Tom, trying to study these things.
I think as a general recommendation, I realize that there are many clinical colleagues attending this webinar, that The key thing is to collect good data and samples. And if you are able to record it, also if you are in Africa, if you have a center, you are able to keep these data and biosamples. There are many people in the world that would like to collaborate. And I think the critical thing is to have high quality data and samples. And then there are many laboratories in the whole world who would like to test these samples for you.
Okay, a couple of more final quick questions before we move on. The respiratory problems, respiratory failure, this is from Ruth Huizinga. The respiratory failure, is it due to paralysis of the diaphragm in these patients, or is it due to the respiratory infection itself, do you think?
Yeah, that's something we do not know. So in the typical Guillain-Barré syndrome, it is really related to the paralysis of the diaphragm and the intercostal muscles. But of course, in COVID-19, you have a combination with the severe pneumonia that can affect that as well. I also know that there are some patients who have a typical COVID-19 and develop then a kind of critical illness, polyneuropathy or myopathy. You may wonder if that is a kind of TBS or if there's a kind of spectrum, an overlap with the Guillain-Barré syndrome, and all that needs to be further examined. So to give a quick answer, I think both mechanisms may be involved in individual patients.
Okay, great, thanks. There are more questions. We'll maybe come back to them shortly, but next we're going to have Netra's talk. If you want to bring up your first slide, Netra. And Netra's talking about the challenges of managing patients with immune therapies, particularly neurological patients.
I think the global health has to allow me to share the screen.
Go ahead, you can do that now, I think. Super, thanks.
Are my slides visible?
Yep, we're seeing those.
Yes.
I'm seeing them.
Well, good afternoon, everyone. At the outset, again, thanks, Tom, for giving me this opportunity in this webinar. So as neurologists, we have many patients who are on immunomodulators and immunosuppressants. So most of the time there is a fear both in the patient as well as in the physician as to whether they are at increased risk in developing a COVID infection, and if so, what should be done? Should they continue, stop? Is there any special precautions to be taken? Thankfully, now we have a lot of guidelines which has come approach from the International Federation of Multiple Sclerosis, British Neurologists, Italian Neurological Society, and we at India brought about a consensus statement on dealing with these patients. So in the next few minutes, I'm going to talk about the challenges what we faced in the last 4 to 5 months in managing these patients with few case scenarios. So this was a young gentleman who came with history of brainstem syndrome since last 2 weeks. He had right-sided INO with right-side cerebellar signs. His MRA fit into the McDonald's criteria of multiple sclerosis. CSF was positive for oligoclonal bands. He was diagnosed as multiple sclerosis and started on steroids. So at this point of time, the dilemma was we are starting him on steroids, whether he's having an increased risk to develop any other infection, especially the COVID infection, and what should be the line of management, which disease modifying agent we should be choosing. We started steroids, patient wanted few days time to think about and come back. So he was just continued on steroids and sent. So because he had a very low lesion load and this was the first episode, we could still just start him on steroids and send. But this is not the case in highly active multiple sclerosis. We should remember that it has taken innumerable effort by the neurologist and hard work to realize that time is brain even in multiple sclerosis. So in patients with highly active multiple sclerosis, we should not delay the treatment. So these are the two patients whom I had with high HAMS, that is highly active multiple sclerosis. First patient is a patient who had from last 5 years, initially she was on other immunomodulators. We started on natalizumab in 2017, but there was a lockdown which was there in our country because of which she was not able to procure the medications. But this is not a situation where we can just stop and not give her the medications. If you see her MRI, she has a high lesion load, extensive atrophy. So she needs to be continued on medication. Similarly, the second patient of HAMS, where she is on, she was also on natalizumab, but she was not able to take the infusion. And if you see her EDSS, it was 7.5, which was quite high. So these are the two patients of HAMS which we had where we could not continue to give natalizumab. But what we should remember is that apart from the standard protocol of giving the dosing at 4 weeks, there is an extended interval dosing where we can delay the infusion by 2 to 3 weeks and sometimes up to 4 weeks also. So this was given, advocated in these two patients, and though there was a delay, we continue to give, and last 2 months they have received an extended interval dosing. So in this pandemic, high active MS, natalizumab is a very good drug, but extended interval dosing would be recommended. So coming to the next gentleman, he had 6 episodes of neurological illness in last 7 years, and he was on rituximab since last 2 years, doing very well. He just had mild gait disturbances and mild behavioral disturbances. The last rituximab he had received in November 2019, and he was due in May 2020. So it is not that 6 months is over, we have to give rituximab. And this era, we need to balance the risk and the benefit. So in his case, because he was not having much deficits and his CD19 was low, we have been just serially monitoring his CD19 without giving the immunomodulation. So such things can be done with monitoring of CD19 and delay the infusion of rituximab. This is another lady, a middle-aged lady who came with history of hiccups, giddiness, vomiting, followed by quadriplegia. So she had a spastic quadriplegia. MRI showed involvement of the cervicomedullary junction and up to C6 cervical cord. Her aquaporin was positive. She was a case of NMO spectrum disorder. We started her on steroids, plasmapheresis. But what about the next immunomodulation? We did not start her on rituximab because she had financial constraints. In our country, the medical expenses are borne by the patient, and she was not able to afford rituximab. So the alternative would have been the azathioprine and mycophenolate, which we wouldn't recommend during this pandemic. So it was not started, but we sensitized her that just giving steroids is not enough. She needs to come back with a frequent review to us so that we can decide as to when we should be starting on these immunosuppressants, either azathioprine and mycophenolate. So if the patient is already on these medications, it can be continued, but it is better to be avoided if you're going to start these medications in this juncture. This is another patient whom we have for many years who was diagnosed with CNS vasculitis based on the cerebral angiogram, initially treated with rituximab, did not have much of improvement, was on cyclophosphamide, maintaining well. So he had received the pulse, cyclophosphamide pulse in March 2020, but we did not continue this in April and May. Instead of that, we converted to oral steroids, which was given. And then eventually now when the health situation was better in his place, this month we have given him the cyclophosphamide pulse. So this has to be avoided during the pandemic. So just like that, the disease modifying agents in multiple sclerosis are categorized based on their risk potential, very low, low, intermediate, and high. So in the very low, we have interferon, glatiramer, teriflunomide, very good. We can start the treatment, continue the treatment, no problem. In the low, natalizumab, as I said, give extended dosing. Dimethyl fumarate, this is one of the drugs where we need to monitor the leukocyte count, especially the lymphocytes, because this is going to decrease. And if the patient develops COVID infection, further it is going to decrease. So it is better to switch the medication in these cases. Ocrelizumab, better it is suspended and alternative medication is given. In the intermediate, we have the oral cladribine, better not to give. It can be suspended and given at a later date. Fingolimod, if they're already taking, it can be continued, no need to change. In the high risk, we have the mitoxantrone, alemtuzumab, stem cell therapy. It's a complete no. These should not be given. These should be suspended. So based on the risk potentials, we can decide as to what has to be given. Similarly, among the immunosuppressants, if the patient is already taking azathioprine, mycophenolate, no problem, continue it. But it's better not to start it. Slight delay can be done. But if the risk is higher, you can start it. Cyclophosphamide, again, complete no, it should not be given. And in the acute therapies, we have the plasmapheresis, IV immunoglobulins. Though they do not have any risk potential, the problem is transit, which has to be done, frequent visits, which has to be done to the hospital. That is one of the problem which is there. Otherwise, corticosteroids, which is there, can be given at a very low dose of 20 milligrams. So apart from this, we need to emphasize that they need to have a behavioral modification, all preventive measures, social distancing, mask, hand wash, gloves has to be emphasized. And if they come under the high risk category, then they should also practice shielding or a self-isolation. And this is the time where our telemedicine needs to be strengthened so that we still keep connected with our patients and manage them adequately. Because we need to remember that just because COVID pandemic has come, the other disorders should not be neglected. And we should try to see that we try to treat them as much as possible through this telemedicine. I sincerely thank Dr. Ravi, Tom, for giving this opportunity and making me part of this BI Global. Acknowledgement to Dr. Bagh, who is always there for all my innumerable questions, and Andrew. Thank you.
Brilliant. Thanks very much, Netra. Netra, thank you.
Thank you.
Let's just get Bart back as well. There we go. I stopped your video, Bart, but if you want to restart it, then we'll be able to have you in the panel. Excellent. So that's really interesting. Thank you very much. It's a really helpful overview. Let's see what questions we have coming in. From Dr. Sonia Tambe. Do anti-inflammatory agents have been thought to be safe in COVID-19? What's your opinion? I guess they're thinking just about things like steroids, etc. What's your feeling about the minor end of the spectrum?
Hello? I'm unable to hear. Yeah.
Did you hear me? Can you hear me?
Yeah. No, I didn't hear. There was some problem with the network.
Okay. What corticosteroids? Are you happy with your patients having corticosteroids?
There are two things, whether we have to give the injectable methylprednisolone or the oral corticosteroids. Depending on the risk, as I said, everything has to be individualized. Oral corticosteroids up to 20 milligram is okay. About 20 milligram would be a high risk. And injectable methylprednisolone has slight increased incidence of herpes reactivation. That we should remember. And if they are vaccinated, it should not be an issue.
Mm-hmm.
Thank you.
Thank you. One question that's come in is how are things going with your patients in terms of discussing these issues? How do they feel about you altering their therapies or even continuing their therapies?
Yeah, actually, I did not bring up that issue because of the lockdown. Our OPDs were stopped and only the casualty services were going on. So what we did is, along with our psychiatry social team, we tried to connect with our old follow-up patients. We called them up, try to see how they are. So we try to allay their fears that there is no problem, continue whichever is possible. Wherever there was an issue, we try to change it. So we were able to communicate to most of our patients and try to change, just like how I discussed in my previous slides.
Yeah.
Tom, can I ask a question too?
Yeah.
So thank you very much for this wonderful presentation. I think it's very helpful.
Thanks. Thank you.
And I realize there are really dilemmas where you have, for instance, a patient on alemtuzumab who cannot really stop this treatment. So it's very important to be absolutely sure that it is not safe to continue with alemtuzumab. And where comes this evidence from that you should not continue because of the risk of COVID-19? Has there been cases published where that were fatal, or is it just the theory about behind alemtuzumab and COVID-19? What's the reason?
Okay, there are two reasons. One is based on one of the things which I did not talk about is this COVID infection has a tendency to cause lymphopenia. So wherever we have patients or who are on disease modifying agents where you have your leukocyte count low or your lymphocyte count low, so that is a place where you need to be of concern. So that is the reason, especially alemtuzumab in the first 6 months, it causes so much decreased lymphocyte count. That is the reason if a person develops COVID infection, we are hypothesizing that they can develop a severe reaction, and that is the reason. Even the dimethyl fumarate, because it decreases the counts, that is the reason sometimes we may need to switch.
And have the cases also been published? So have there been really case reports with patients who die after developing COVID-19 and alemtuzumab? Are there reports on that?
Yeah. Till now, there's just one published case where a patient was on ocrelizumab and he developed COVID infection, but he improved completely with quarantining itself, self-quarantine at home. That's all. So it was actually hypothesized whether that low B cell count actually prevented the cytokine syndrome and actually was actually protective for this patient. This is the only published case, but actually if we go in, there is one, I think BI Global also is trying to recruit patients who have developing neuro patients who are developing COVID, as well as there is a COVIM study and Quenta. They are trying to recruit patients who are on neurological disorders taking treatment and who would have developed COVID. I think they're still under being collection, and maybe we will know in the future as to the answer for your question.
Okay, thank you.
Thank you.
Thanks. There's a comment here from Jane Hassel about children and adults. In adults, this relates actually back to GBS. Have you seen GBS associated with multi-system inflammatory syndrome in children? We've seen a number of children with this multi-system inflammatory syndrome and isolated bulbar palsy with primary diagnosis of pediatric inflammatory multi-system syndrome and SARS-CoV-2. This is Jane, a pediatric neurologist in London. I think this multi-system inflammatory syndrome is it's on the Kawasaki spectrum, isn't it? That's Kawasaki where this spectrum issue has come from. Yeah.
Yeah. I think that's a very important observation. I've never seen that. I've also don't know that there are any reports on that in children. So that would be very important to further investigate this and maybe publish this as a case report.
I think so. Yeah. And just back to Netra, there's not much evidence in this space. It's all being derived empirically, like you say, with the odd case report. Do you know what efforts there are ongoing to try and really generate evidence about how to manage patients with these on these therapies?
One thing would be that we could start collecting the data on all the neurological patients as to whether, like how we did call up most of around 300 patients to see who are already on treatment, whether they had developed any problems on medications. Apart from this, we also could do like what I told about the previous studies which are being done, try to collect all the patients who are on these medications, even for CNS as well as PNS disorders, and try to see what happens, whether they develop the COVID infection and what is the severity. And
thank you. Just another question here on the GBS variants. Do you expect SARS-CoV to be associated with any particular variants, like AMAN, acute motor axonal neuropathy, or AMZAN, motor sensory axonal neuropathy?
Well, I know that there are some preceding infections like Campylobacter or hepatitis E virus that are related with a specific variant. That if you find this association, that strengthens your evidence that there is a real causative role. If there's no association with the clinical phenotype or subtype, then that does not exclude, of course, that it can play a role. But I think it can add evidence, and we just have to see. What I notice is that most of the patients that have been reported so far have a rather severe cranial nerve involvement as well. So maybe that's part of the typical phenotype, but we have to see.
Absolutely.
Can I ask a question to Bart?
Yeah. Yes, go ahead.
Yeah. But among these GBS syndrome, which you said, were there any patients who were like post-infection or para-infectious who did not improve with plasmapheresis or IV agent, you had to give steroids?
Yeah, so most of them are post-infectious, but some of these cases are relatively short after, let's say, the first symptoms of the respiratory problems related to COVID. Of course, you don't know if it is then really infectious or peri-infectious, because the infection may be 1 or 2 weeks before the first clinical manifestations, and then it can still be post-infectious. And I think because of that, it's very important to do immunological research and see what exactly is the mechanism. So far, the virus has not been identified in the CSF, for instance. So that is a bit arguing against a direct infectious role.
in the GBS patients you're talking about. It has been detected by PCR in CSF of a small number of patients, hasn't it? But as far as we're aware, not yet been cultured from any spinal fluid. So if somebody out there wants to get the first, I mean, everything's happening so rapidly in the era of COVID-19, but if you still want to be the first to something, you could be the first to culture the virus from spinal fluid. We're nearly finished now. I've got one more question and then a couple of wrap-up slides. This is a question from Karuva Mallikarjuna, and it's great. So we played some music at the start of this webinar. I don't know if people heard it and appreciated it, but it was technically very challenging to do. I think that's why we ended up with the echo, because I had some music playing. But anyway, this is the question. Are any studies being done about music therapy or self-esteem on COVID outcome? Anyone want to take that one up?
I'm not aware of that, but I'm sure that will have one of the thing is post-infection, like how we have affection of the encephalon, whether they will develop like a post-traumatic syndrome. So and minor cognitive impairment or behavioral changes. I don't know, it's just a theory that it may help in such patients with these music therapy, but I'm not aware beyond this.
Yeah, they do. I mean, in Bangalore at NIMHANS, there is a big music therapy department that I've seen. So, you know, it's a wonderful way of tackling these things. I don't know if there's a music therapy department in the neuroscience unit at Erasmus, Bart.
No, not yet, but maybe it should. And I think I realized that what you said is, so basically we'll have a lot of stress and you have a kind of post-stress syndrome. Most of the GBS patients have them, and we should pay more attention to that. Maybe music therapy can there play a role, but so far I would be interested. Do you have a recommendation for the music, or is that very personal?
Play anything. I think anything.
Okay.
So I'll just show, I've got a couple more slides to show just before we finish. And also whilst I'm doing this, I would say to people, if you want to be kept updated with future webinars, etc., and other activities, just post your email address now on the chat function, because we don't always have access to, even though you've registered, sometimes it's not straightforward. So if you do want to keep in touch, post your email address, and we'll leave the chat function open for a little while. So this is just to finish off, as it were, a reminder of these resources on the Brain Infections Global webpage, the COVID Neuro resource, so that you can get hold of case record forms, keep up to date with publications, and indeed join the individual patient data meta-analysis. If you have data that you want to become part of this meta-analysis that we're in discussion with the Lancet Neurology about, then please do get in touch for that. There you are, those are the links. I was also going to say that if you can't get enough of webinars, and I know some of you spend your whole life listening to webinars and podcasts, tomorrow lunchtime at, I think it's starting at 1 o'clock, we have this Scouse Science podcast, which is we're looking at some of our science in not such a serious way, explaining it to the public. We've got one of our fantastic social scientists here, Sally Sheard, who's doing some really interesting work on COVID-19 and policy. She spent time with the chief medical officers, the last 4 chief medical officers, finding out what they really get up to. So if you want to find out what really happens in a pandemic, join that webinar. And also we have Frank Cottrell-Boyce, who is a local author, has written books like kids' books like Millions. So I'll post again on the chat, I'll post the link for those that want to register. And I just wanted to thank our speakers again for very informative talks, Bart, Jacobs and Netra, and thank you all for attending.